in February here at the GIC. I am Valerie Sullivan and I am chair. And I'd like to welcome everybody here today, especially our YouTube listeners. So I'm excited to be here today and want to introduce the commissioners who are here on this meeting today. So I'm joined by Vice Chair Bobby Kaplan, Designee Dana Sullivan for ANF, Designee Rebecca Butler for DOI. We have Darren Ambler, Toby Choate, Martin Curley, Tamara Davis, Jane Edmonds, Gersino Gerard, Eileen McEnany, Melissa Rodriguez, Kristen Pepin, Dean Robinson, Jason Silva, Anna Sinenko, and Catherine West. So thank you all. I know it's been a very busy few weeks since our last meeting and appreciate everyone being here today. I'm now going to turn the meeting over to Matt, and we're going to review our agenda for the day. Good morning, Matt.
Good morning, Madam Chair. Good morning, Commissioners. Good morning to those dialing in through YouTube. We're delighted to have you here today for an important meeting. So today, if we can go to the agenda slide, we will revisit the FY27 plan design changes. A vote was postponed at our last meeting on February 12th. During that meeting, the Commission requested some additional data and analysis, which Margaret Anschutz, our Director of Health Policy and Data Analytics, will present to you today. Following Margaret's presentation, Commissioners will have an opportunity to make motions relative to votes on any plan design changes. Then we will have our CFO, Jennifer Hewitt, who will present a CFO report for the current fiscal year 26. We had also planned, as you'll see on the agenda, to have our Deputy Executive Director, Erica Schabelli, present an update on VITA implementation and member interactions to date. This was something that had been requested of us by commissioners. However, Erica had a family emergency and is not able to join us here today. So we will be postponing that, but only for a week, to our meeting on March the 5th. We had also intended to bring the PBM consultant procurement recommendation for a vote, but just given we wanted to make sure that we had time and sufficient bandwidth in this meeting to have the discussions on plan design. So we've moved that to March the 5th as well. So just a 1 week delay on that. So that is our agenda for the day.
Okay, we got a lot to cover. Thank you, Matt. So before we get into the meat of the meeting, let's have a vote on the minutes. So I'll entertain a motion to approve the minutes from the last February meeting.
So moved.
So that was Bobby, and then second by Dana. Okay, so thank you both. Andrew, I'm going to have you do roll call, but I'm an aye.
Thank you, Chair. Vice Chair Kaplan.
Aye.
Designee Sullivan.
Aye.
Designee Butler.
Aye.
Commissioner Ambler.
Aye.
Commissioner Choate.
Aye.
Commissioner Curley.
Aye.
Commissioner Davis.
Aye.
Thank you. Commissioner Edmonds.
Aye.
Commissioner Guerin.
Aye.
Commissioner McEnany.
Aye.
Commissioner Murphy Rodriguez.
Yes.
Thank you. Commissioner Pepin.
Aye.
Commissioner Robinson.
Aye.
Commissioner Silva.
Yes.
Commissioner Sinenko.
Aye.
Commissioner West.
Aye.
It passes unanimously.
Okay, all right, thank you, Andrew. We can keep moving on the agenda. So
Great.
Matt.
Thank you, Madam Chair. Since our last meeting, since staff were deeply involved in supporting the data analysis that we'll present here today, we did not produce an executive director's report, but we will have one for the March 5th meeting. I did want to take a brief moment to welcome back Janine Dewar from our vendor management team. She's the manager of pharmacy and ancillary benefits, recently returned from a parental leave this month. So congratulations to Janine on the newest addition to her family, and we are thrilled to have you back. That's the extent of my ED report.
Nice. All right. Well, welcome back. So Matt, you're on a roll. Keep moving.
All right. So we will move directly into plan design. I will just say a few brief words and then hand it over to Margaret Anschutz. Again, this is the plan design vote that was postponed from our last meeting, and we will have Margaret present on the data analysis that we've shared with the Commission last week. And I just want to recognize the team that's behind this presentation. Margaret will be presenting, and she leads that team, but other members of the team, Lauren Makashima and Jiangsu Li. The Commission's request, as you know, was extensive and required a very significant amount of data to be compiled and validated and analyzed in a very short time frame. So this team worked closely with essentially every unit in the agency. This was an all hands on deck effort on our part, also working closely with WTW. We want to make sure that we're bringing you information that is accurate, complete, and responsive. And it gives me a great sense of pride and satisfaction to have this team perform at such a high level. I've felt from the beginning of my time at the GIC that we really needed to have a robust data analytics department, and here it is really paying off for the Commission to give you the information that you need to make the decisions that you make. I also want to note briefly that that in addition to the analytics materials that we provided last week, we've received a good deal of additional feedback from our members, which we have also shared with you all, an additional 200 pages of members expressing their voices and opinions to us. We also, late Monday afternoon, just want to acknowledge that we shared with you a letter from Governor Healy that recommended that the Commission consider only approving the proposal to eliminate coverage for GLP-1s to treat obesity and to leave aside the remainder of the plan design changes. This is a significantly scaled back budget savings exercise for us. And since the budget was filed back in January, just want to note that approving only this one change on GLP-1s would leave a gap between our projected spending and the funding level that's included in House 2. So with that, I am happy to turn it over to Margaret to present her summary of the analysis. Margaret?
Yeah, thanks, Matt, and good morning, Commissioners. Let's go to the next slide. All right, so first for the agenda. As Matt said, I'm here to present additional data that you requested. First, we're going to go through some data on cost of living and health benefits. I have a slide for you that shows how much cost of living expenses, including healthcare premiums, have increased in the Northeast since 2022. Then onto benchmarking GLP-1 coverage for obesity. I'll talk about national coverage rates for GLP-1s in the employer market. Matt will discuss coverage in Massachusetts. Number 3, member scenarios. I will walk through 2 member scenarios to show how proposed benefit design changes would affect 2 different members. And 4, we'll go to the benefit design change, and the agenda will be turned over to you to discuss these proposed changes. Next slide. The purpose of this slide is to contextualize GIC premium increases alongside wage increases and other cost of living expenses such as childcare, food, housing, and regional inflation. First, to orient you to this graph, on the x-axis along the bottom, we have the years 2022 through 2024. On the y-axis, the graph shows the cumulative increases in each of the variables we're tracking over the 3-year period. The 2 takeaways from this graph are: 1, healthcare premiums are increasing faster in the Northeast market than in GIC plans, showing that rising costs are tied to the market and are not specific to the GIC. Number 2, median state employee salary growth is growing slower than the growth in premiums, childcare costs, and food costs, while housing and regional inflation are growing too, though not as quickly. So now I'll walk through in more detail. The steepest line on this graph, indicating the largest change, is the premium increases in the Northeast, with individual plans increasing 17.5 percentage points and family plans increasing 18.2 percentage points, according to Kaiser Family Foundation. Compared to the next 2 lines down, GIC individual premiums grew 13.2 percentage points, again, compared to 17.5 at the benchmark. And GIC family plans premiums grew 14.9 percentage points compared to the Northeast benchmark at 18.2. Again, these increases are seen across New England and are not specific to GIC. Turning our attention to the median state employee total pay, the black line with the box, we see that median salary has increased 9.5 percentage points, not keeping pace with increases in healthcare premiums, childcare increases at 11 percentage points, and food increases at 11.5. We also have growth in housing and regional inflation that falls below salary growth, but it's still an increase, straining households, particularly lower income households with little discretionary income to absorb rising cost. So everyone's really feeling the pinch right now. Next slide. Here we have a look at GLP-1s in state employee health plans. GLP-1 coverage is straining healthcare budgets across the country. You can see on this map that 17 state employee health plans like the GIC are still covering GLP-1s for weight loss. Of those 17, at least 3 have implemented weight loss management vendors alongside coverage. So that's like us with Vita. You will recall that 22,000 GIC members are taking GLP-1s for weight loss at a cost of $46.3 million to the state budget and representing 2.4 of our aggregate rate increase. These drugs are expensive, but they're also life-changing, as you have heard from members in their recent communications. And as you've heard from me before, eliminating coverage for GLP-1s will have a disproportionate effect on the health of lower income members who won't necessarily have the funds available to pay for them out of pocket. When people stop taking GLP-1s for weight loss, the weight usually comes back within 18 months, and associated health gains are lost as well. Moreover, chronic conditions associated with obesity, such as coronary artery disease, hypertension, and diabetes, are overrepresented in the BIPOC community. Gains we are starting to make in reducing prevalence across the population and closing health disparities around these chronic conditions will also be lost for members who can't afford to pay for GLP-1s out of pocket. Next slide. Now let's look at coverage rates nationally by employer size. But first, where does this data come from? Data shown here comes from WTW's national survey of 417 organizations representing 5 million employees. The survey was conducted in summer of 2025 and is the most current data available. On the first line, 100 to 99 employees, it's not surprising that we see small employers declining to cover GLP-1s. They have a small risk pool to spread the medical costs around to, and most are fully insured. Only 28% of these employers cover GLP-1s and are not considering dropping coverage. As you move down the chart, employer size increases and so do the rates of coverage until you get to the largest employer size, where GIC would sit. For employers with 25,000 or more employees, 46% of them cover GLP-1s and are planning to maintain that coverage, while 19% of total employers in this bucket had coverage at the time of the survey but were considering removing it. Overall, the slide shows that a large number of employers across the country and industries still covering GLP-1s, and coverage is a decision that many are wrestling with as a cost-cutting measure. I'm going to turn it over to Matt for the next slide.
Thank you, Margaret. So here we were asked to provide some additional information about coverage in the Massachusetts market. And I'll start just by noting, as we have at the top here, that there's very little current publicly available data current to 2026. So what we did was an informal survey of the market that indicates that coverage for GLP-1s to treat obesity in Massachusetts has retreated significantly since January 2025. As we've talked about before, and there's been some news coverage, many carriers took steps to eliminate coverage consistent with DOI guidance and eliminated it from their standard plan offerings. It appears that coverage is not offered by any major commercial insurance plan in the merged individual and small group market, and that includes plans offered through the Health Connector. None of the major carriers in Massachusetts, large group, and this is fully insured and self-insured, offer coverage for GLP-1s for obesity as part of their standard plan offerings. But they do, as Margaret noted, as we see nationally, that clients may add that coverage for an additional premium increment. We have heard from carriers that we've surveyed, again, informally, that additional cost to add GLP-1 coverage is between 5 and 8 percentage points. So uptake on this buy-up, as you can imagine, is reportedly quite low. Varies by carrier. From what we heard, between 5 and 20% of employers are adding that coverage. The larger the employer group is, similar to what Margaret, but not exactly to what Margaret showed in the national market, the larger the employer is, the more likely they are to maintain coverage. But that does seem to cluster among employers in the life sciences and healthcare industry. I think Darren Ambler had made that point in a prior meeting. I do want to note that carriers that do not provide coverage, they have seen a material increase in utilization of these same drugs when they're prescribed for other conditions that are covered, diabetes, sleep apnea, and a handful of other conditions. So carriers are taking steps to tighten utilization management to ensure that that we don't see sort of inappropriate migration into these other coverage categories. Elsewhere in the marketplace, MIA, which is the Massachusetts Interlocal Insurance Association, this is a subsidiary of Mass Municipal Association, a major cover of municipalities in the state. They are also eliminating coverage for their offerings for the coming plan year. And then finally, Mass Health, which has provided coverage for GLP-1s for obesity, has taken the step as a result of the budget that they got, is moving to remove GLP-1 coverage as well. This mirrors actions taken in a handful of states that we see listed here. So that's my informal data gathering that we could do in a week or so of what's happening in the Massachusetts market. Happy to turn it back to Margaret.
Great. Thanks, Matt. All right, next slide. Yeah, great. Okay, we're going to move on to member scenarios. I will walk through 2 member scenarios showing how premiums and out-of-pocket costs accrue to 2 different fictional members, both under the status quo copay structure and if all benefit changes are made. In scenario 1, our member makes $55,000 a year. Her salary places her just below the lower 10th percentile in the state salary range. She has coronary artery disease and type 2 diabetes. Given that her salary leaves little room for additional spending, she has deep concerns about how increased out-of-pocket costs will hit her budget. We learned from the 2021 member conjoint survey that our members slightly prefer an increase in premium to an increase of out-of-pocket costs. For many members, budgeting for the regular premium deduction makes costs more manageable, but when point of service costs such as copays and deductibles increase, those unbudgeted costs may place lower income members in the position of choosing between food and healthcare. Her healthcare utilization is shown in the top right box, which also shows how her costs change if all proposed benefit design changes are enacted. And here's her story. In July, at the beginning of the plan year, she goes for a wellness visit, which does not have a copay associated with it, nor does it accrue to her deductible. In a follow-up visit, to manage her type 2 diabetes, she visits a specialist in July, paying $400 toward her deductible. In a follow-up visit to the same specialist, $250 of the $400 specialist charge accrues to her deductible, as the deductible is now $650 instead of $400, and she has met it. The remaining 4 specialist visits cost her $70 copays each if the proposed benefit design go through, an increase of $10 per service from our current state. At an emergency room visit, due to hyperglycemia, she is successfully treated and not admitted to the hospital. The resulting copay is $150, a $50 increase from the current state. Her retail, generic, and mail order branded prescription copays do not change. At the year end, if all proposed benefit design changes are adopted, her total healthcare spending increases by $176, as the effect of the increased copays is larger than the effect of the lower premium associated with the cuts. Next slide, please. Okay, member scenario 2. This member is a 25-year-old state employee earning $90,000 a year, which is just under the median salary for state workers. She's in WellPoint Community Choice individual plan and is a lower health risk than the average utilizer. Being a low utilizer, her primary concern is around minimal premium increases. Looking to the top right box, we see her healthcare utilization in the column second from the left, and the related copays if none of the proposed benefit design changes are adopted in the column second from the right, as well as her copays if all of the proposed benefit design changes are adopted. She has a preventive visit, which has no associated copay and no accrual towards deductible. Later in the year, she is ill and sees her PCP, who prescribes her antibiotics. The PCP visit costs her $175 toward her medical deductible, and the prescription cost is $40 that accrues to the prescription deductible. In this scenario, if none of the copay increases are accepted, her yearly expenditure from out-of-pocket costs and premiums is $2,988. Should the copay benefit changes be accepted, she spends $104 less for the year due to reduced premiums. Her out-of-pocket costs here are the same in each scenario as they come in under the deductible. All right, next slide, please. All right, moving on to the requested weighted average for non-Medicare individual and family plans. The weighted average for non-Medicare individual plans is $1,214, and for families, it's $2,934. Note that this is the full cost premium, not the member share. So I heard requests for a average to consider. These two weighted averages, one for individual, one for family, they're there. But the purpose of this slide is really to provide the weighted average, but I am wary of presenting this number to you without also discussing the variation in the premium rates around that weighted average. An average can hide variation, and so I want to talk a little bit about that variation. Again, the non-Medicare individual weighted average premium is $1,214, but I want to discourage you from really anchoring to that number. You can see in the middle, 50% of our members in individual plans fall into a premium range of $989 to $1,321, and the lowest premium is $923, with the highest at $1,870. So that's quite a range around that average. All right, the same dynamic applies to the weighted average premium for family non-Medicare plans, with the weighted average at $2,934. And the middle 50% range coming in at $2,523 to $3,278. Again, that's a lot of variation around the weighted average, and so please keep that variation in mind as we go on. Next slide. Finally, here's a waterfall chart showing the weighted average premium, what we just discussed, for non-Medicare individuals and family plans, along with the dollar decrements for each benefit design change tagged to that average. Because this is a weighted average, as I just discussed, this example is for illustrative purposes only. Members will see considerable variation based on their plan. The top graph shows how the proposed benefit design change affects the individual premium. The bottom shows the same for the family premium. Running quickly through the individual proposed benefit design changes, you'll see that increasing urgent care copays are not associated with a material change in premium. Increasing ER copay shaves $1 off the premium. Introducing a 40% coinsurance for out-of-network services reduces the premium again by $1. Increasing PCP and specialist copays reduces the premium by $4. Deductible increases reduce premium by $10. Hearing aid coverage lowers premiums by $1. And with the greatest impact on premium, eliminating GLP-1 coverage reduces the weighted average premium by $28. Note that the same lesson and variation around our weighted averages applies to this example. The actual amount that enacting any benefit change will reduce premiums by varies widely. And similarly, on the bottom graph, the weighted average for non-Medicare family plans is on the left, with decrements associated with each benefit design change listed across the graph. And the weighted average for the plan, should all changes be accepted, on the right.
Yeah. Hi, hey, Margaret.
Yeah.
Anna has her question
I would
raised, but
love to take it.
also Dana had a question earlier. I was holding questions, but
this is just clarification, Margaret. Is this the total monthly premium that we're looking at?
Total monthly premium, so not the member's contribution, total monthly.
But it's only monthly, it's not annual.
That's right.
Great, thanks.
And I'm happy to take more questions. This is the end of my slides.
Okay, great. So Dana, I know you had your hand up. Go ahead and have the floor.
Thank you. I first really want to thank the GIC team for putting this together. I recognize how much work it has been to gather this data, and I think from a commissioner standpoint, it has been really valuable to see the concrete impacts of these proposed changes on our membership. So really thank you for pulling this together so quickly. I also really appreciate the collaborative discussion we've had today and have been having for months about this. As the executive director mentioned earlier, and we've heard directly from Governor Healy now. So our administration is really focused on prioritizing healthcare affordability. And I know this commission does too, which is why we've been discussing these changes for so many months. Given the new data we've received and the discussions we've had, I don't think now is the right time to consider the cost shifting proposals currently before us. Instead, in line with the governor's recent letter, I ask that we focus on the question of GLP-1 coverage for weight loss. It's certainly not an easy decision before us. No one likes talking about limiting access to effective drugs, but I believe it's a strategic one. As we've just heard, many private and public health plans have decided to drop this coverage given the mounting costs. And the hope that their actions help secure more affordable, sustainable pricing. As the largest purchaser of health insurance in the state, the GIC has a unique opportunity to contribute to these efforts. And I want to reiterate the governor's commitment that the work won't stop here. While we make this near-term change, the Healthcare Affordability Working Group will focus on what I know the commission really wants to address, the underlying drivers of growing healthcare costs. And the work has already started. The group is meeting, GIC is a part of it, and the governor's committed to advancing longer-term system-wide strategies to reduce healthcare costs in FY28 and beyond. And so I hope you will vote to remove GLP-1 coverage for weight loss while the broader work is ongoing. And so then I would like to make a motion to amend the previously tabled vote to decouple GLP-1 coverage and consider removing that for weight management beginning in FY27.
All right. Well, thank you, Dana. I don't think we have a second yet, so I think we can.
Second.
All right, so Rebecca is seconding that. Can we have some discussion around this? Because I see lots of hands up.
Yeah.
Andrew, I feel that
Yeah.
is available. Okay, Tamara,
Yeah.
Madam Chair, point of order, it isn't a motion to amend since there was no motion made previously. It is simply a motion to consider dropping the GLP-1 coverage.
okay. So I have a motion on the table based on this data, to eliminate GLP-1 coverage for obesity. And it was made by Dana and seconded by Rebecca. So now can we have discussion, Andrew?
Yes.
Okay.
Mhm.
So Tamara,
Good.
you have the
Thank-
floor.
Thank you, Madam Chair. With all due respect to Dana and the governor, I think we as a public body have to represent objectively, neutrally, all of the constituents that we represent. And Dana, you did a great job advocating for the governor, by the way, in the state, which is your job, of course. But I was very impressed. But before we even consider any votes, I think we need to really have a discussion around both of these scenarios that we've been talking about, the premium changes and also the GLP-1s, which are two different things and have different impacts. And I also would suggest that we need to think about this more than putting out this fire as to what we need to do now. And I know we do have to do something now, but we need to think about it in terms of a multi-year kind of strategy. So what I would suggest and put on the table for discussion also, sort of, and I believe in equity for all, which is very, very hard to do, I know, but it is, I think there's a balance that we could have. And one of the things that I've been thinking about is that we might be able to look at these changes. First of all, in the premium, the employee only pays, what is it, 10 to 20%? From what I understand, is that, I'm not sure what the exact number is in terms of the employee input.
10 to 25, 10 to
25%
of our
So
state
we have to keep
employees.
that in
Yeah.
mind. So it's not that number. It's the 25% that we're talking about in terms of the impact. But what I would suggest is look at this as sort of a 2-year kind of strategy. And I know we cannot vote on anything for subsequent years, but if we think about this in terms of possibly having a lower increase in premium, in other words, split the suggested increase in half and do half a lower increase, such as the deductible, a lower increase this year, and then reconsider it next year based on where we are. In other words, it instead of completely disregarding cost sharing, I think we need to consider cost sharing, but maybe at a lower amount, and then also look at GLP-1s. And one of the things that I might also think about in GLP-1s, which may or may not be feasible, is that where there is some payment, such as a deductible for GLP-1s paid by the employee, and maintain them. And I know that is something that could be somewhat problematic with manufacturers and PBMs, but I think we need to think about this rather than saying no GLP-1s and no cost sharing. I think we need to think about it sort of in a balanced way, where we might look at this over maybe this year and next year, rather than just saying we're not going to do it, because I think that's not fair to many of our constituents.
Thank you, Tamara. Jane, I know you had your hand up.
Yes.
Eileen and then Bobby.
Thank you so much. In many ways, I would echo Tamara's comments. First, I'm very grateful that the governor has sent a letter to us to spell out some of the concerns, which are formidable, and I appreciate that. But I also appreciate that she's put all of us, those she's appointed, to exercise our judgment. And I continue to struggle with these issues, and with all respect to the fine presentation that's been made this morning, those two scenarios in particular, they strike me more as a cost pressure narrative than they do to give me enough information to make me feel comfortable that I better understand as Tamara points out, the fiduciary, clinical, and policy questions related to a vote. And so, my bottom line this morning is I would strongly prefer and urge that we do use the next year to explore a more, what I'd consider nuanced and sustainable solution that includes clinical criteria and phased transitions and negotiated pricing strategies and all the stuff that goes along with this type of analysis rather than a blanket immediate transition. Those scenarios that were shared with us today, in my humble opinion, do not represent the scenarios that I have heard and read in terms of a large number of emails that have come my way, talking about what the implications would be. They downplay the harm. And I think it's very important for us as those charged with making tough decisions, not just money decisions, but human conditions, that we have the information in a better form before total elimination. This would be, to my knowledge, the first time the commission would be eliminating a proven evidence-based kind of offering that's making a difference to our members. Think about that. This documented. We know, we have the data that it's making a difference in people's lives. So there are a host of questions that are so complex. I have a laundry list of questions that I've developed just for myself that in good conscience I would need to know. So it's probably pretty clear that I could not vote to eliminate coverage. Thank you, Madam Chair.
Thank you, Jane. Go ahead, Eileen. You might be on mute, Eileen. We still can't hear you, Eileen. Can anybody else hear Eileen? No.
No, I think she may have a mic problem.
She's definitely muted.
Yeah, now you're muted, Eileen. Nope.
Sometimes you can unmute as the host. Can you check that before we move on?
Yeah, she's unmuted.
I have checked and tried. I think it's a mic issue.
Okay.
We'll come back to you, Eileen.
Yeah, we might need to go to settings. So go ahead, Bobby.
Thank you, Valerie. I just want to sort of echo Jane's point. First of all, I appreciate the governor, sort of recommending that we not shift costs to employees, that we not increase copays and deductibles. However, having read literally all the materials over the last couple of weeks and all the emails that we have received, and knowing that, Vita Health has just begun, we don't have any, real data on the enrollees. We know that, to Jane's point, the disparate impact on low-income workers, on people of color, on, single-parent households, what that will do we've all read, at least some of the emails from the members that we cover. And as everyone has said, we are the largest, health insurance procurer in the state. And to eliminate coverage, I first of all cannot in good conscience vote to eliminate GLP-1 coverage. I think that we should perhaps, I would like to see us perhaps establish a subcommittee that works with the healthcare affordability work group, that we spend time. I mean, all this data and all this analysis, and I appreciate everything, all the data that Margaret and her team have compiled, all the work the GIC staff has done. It's incredible work. And there's a tremendous amount of data, but everything points to the disparate impact and what will happen long term. This is a short-term fix, if you will, that is going to increase costs exponentially over the next few years. When we see the actual impact that removing these GLP-1 medications for weight loss show us. Just today, right, there was an article that Moderna, in conjunction with, I forget which pharmaceutical companies, they're going to work on a pill, right? Create a pill for weight loss, which, and yesterday, I think it was Novo Nordisk that announced that they're reducing the cost of medication, the retail price of Wegovy and Ozempic by 50%. And, very soon the cost may go down, but we cannot, I propose that we vote against eliminating GLP-1s and just leave the coverage as is. Employees have clearly stated that premium increases, they can understand. As I've said many times before, they are spread out over 24 pay periods. That increase, whatever the increase is, people have the opportunity to change plans, but the increase in their contribution is not as great because it is spread out and people can plan for it and it's a pre-tax benefit as opposed to out of pocket, because what it will cost people, only people with high incomes will be able to afford the GLP-1 medications for weight loss. And it is a incredible, the inequity of that decision is going to, speak volumes to our members who are on it, those who are waiting to be approved, because the improvement in health benefits, that savings alone, will demonstrate for years to come, right, that it's a good decision that we're making to not eliminate GLP-1s.
No, thank you, Bobby.
It's
I want to weigh in here. This is a very challenging budget year for our state, and our responsibility as commissioners is to focus both on the taxpayers and our fiduciary responsibility to budget along with our members and our constituents. And I do feel that we've been given some focus based on what our members want. And I really do care deeply. And the cost shifting is challenging for them. It's not what they want. And we've heard and we have direction from our governor that this is not what we should be doing. At the same time, looking at this slide, to make some degree of fiduciary responsibility, it does look like GLP-1 coverage elimination for obesity will help us from a budget perspective. And I do believe that because there is this wave of dropping coverage. There's lots of innovative solutions that have come about. Companies like Waltz Health and Transcarent have a solution for employers that allows us to be focused on giving the coverage, but also working with the manufacturers to continue to reduce the prices. So I do think this could be an opportunity for us to exercise our responsibility to both our members and to our taxpayer constituents. And while nobody likes to eliminate and say no, this might be an opportunity for it to be a 1-year gap before the health commission that the governor has put together has a solution, and we exercise our buying power. So I do want us to remember our full responsibility and see if we can come to a way to be serving in that capacity, which is never easy. Dana, I saw your hand go up, and then Dean's.
Thank you. No one likes talking about limiting access to effective coverage. I think these are really hard decisions, and we've seen a lot of other folks have to grapple with this. So the private market, Mass Health, Maya, and 35 other states have already acted in this way. But there's a long-term strategic reason here that I want to make sure that we can all see. We're hopeful that if we leverage the GIC's market power, the private market and Mass Health collectively can push the price of GLP-1s down to get access to this coverage for our population. As the largest purchaser of health insurance in Massachusetts, we're a crucial part of the effort. And so if we continue to cover, there's no incentive for them to come work with us. If we cut coverage, collectively, we have market power to push those prices down to get access for our membership. I also just want to bring back to some numbers because there's a direct relationship between the changes being considered and the rate vote next week. And so the recent projected double-digit premium rate increases are not sustainable for anyone. But the changes adopted by the commission at the last meeting and the elimination of GLP-1 coverage in this meeting, it would bring our premium growth down to an average of 7.5%, which is the smallest average increase in years, providing much relief to all members.
Thank you, Dana. Dean, I think you were next. Go ahead.
Kind of had a procedural question. Commissioner Dana Sullivan made a motion such that we could take up plan design changes for a vote. I guess what I'm getting at is, can we kind of break the agenda such that we're voting on everything but GLP-1s, and then we could take that up separately, because I think it's worthy of more focused discussion.
Yeah, I mean, I can let Andrew speak, but we do have a motion on the table to not review the cost share and just move to eliminating GLP-1 coverage. And now we're debating that. So people are weighing in on that. And that is the motion. If you'd like to make another motion, I believe we have to vote on the motion that's on the table, and then you can make a new motion, Dean.
You could move to suspend the motion that's on the table and make an alternative motion. But first you'd have to move. It'd have to be a vote on suspending the current motion.
Okay. Darren, you have...
In essence, you'd be tabling the motion temporarily.
So if we can continue to debate this, potentially, Dean, you could make an alternative motion. So I'm going to let Darren take the floor so we can hear from as many commissioners as possible.
Thank you, Madam Chair. Yeah, so I'm looking at all of these numbers. One of the things that really sticks out to me, the average, the effective premium rates here, I think we need to recognize are significantly higher than the private market by probably at least 30%. So this plan has a pretty serious utilization issue. And, we're in some degree, some of these things are, it's a sinking ship and you're throwing deck chairs over. So going through the motions of, negotiating pricing and things like that could bring the average claim rate down or the unit cost down, but it doesn't necessarily change utilization patterns that are in place here. Plan design changes can affect that utilization pattern. And I think that that's really important to consider is that we have a utilization issue and we can have some degree of control over that if we can consider some of these changes. And certainly GLP-1 is a huge one. And when I get to GLP-1s and I understand the effectiveness of these drugs, but we only have 18,000 members who are utilizing access to that medication for weight loss use. And out of 460,000 members, so roughly 3.5–4%, that's really a situation, for lack of a better term, a tail wagging the dog. And it's a huge expense for the program. And we all know that, the private market is moving away from this. They've dropped it quite a bit. And we are driving that demand as a huge plan, one of the largest in the country. We're driving demand, and demand keeps that price up. And if we can have plans remove that benefit, that demand will change and the pricing will have to come down. And we know that the cost benefit analysis of these drugs right now is still not there. The benefit does not outweigh the cost. But that could change fairly quickly if these drug costs could come down. And I know there's some proposals for them to come down, but it's going to be very slow. It's not going to be within the next 6 to 12 months. It's going to take longer unless demand changes. So if demand does change for these drugs and the drug cost does come down, we can really look at bringing this back. I mean, I would be the first one to say that if we eliminate this drug and that cost benefit analysis changes, we need to get this right back in. Countless times over the years, I've recommended plan design changes that on the face of it look like an added cost for a plan, but you do it because it's actually going to reduce costs over time. And those plan design changes are extremely important to take. And we do have really two parties here. We have the plan participant, the employee of the state and the municipalities who participate in this plan and their family members. And there's a duty to them, but we do have the duty to our constituents as well. And most of those constituents do not have GLP-1 benefits. They also don't have a health plan that is this rich. That's just the fact of it. And they're subsidizing a great degree of this program. And I understand that the state employees pay taxes as well, but there's a big difference between a participating taxpayer and one that doesn't get to participate in this plan. So I think that I said there's a utilization problem, and this plan is driving demand. And if we can change that, we can start to affect pricing in a very real way, to the point of taking out of Mass Health in this plan as well. You've really changed the buying power in the market and that demand, and we can bring it back. And like I said, I would be the first one to put my hand up and say, you know what, the benefit analysis shows that this will reduce costs for our plan moving forward. Let's bring it back.
Yeah.
Thank you.
Thank you, Darren. Appreciate that. Eileen, has your mic come back online?
Can you hear me now?
Oh, yes. Excellent. Go ahead, please.
Okay. Thank you. I'm sorry about that glitch. I want to thank the GIC staff. I know you're doing, a ton of work in a short period of time and want to acknowledge all of your efforts. I also, I want to thank Dana for saying explicitly that the administration is committed to addressing underlying cost. And I, for one, will hold you to that because I don't want to be having this conversation a year from now. And I will be offering a motion in other business to seriously think about ways we're going to do that. I also just want to share this has been a huge struggle, I can tell, for all of us. These are tough decisions. And I guess part of what I think is when we talk about like equity, right? I do think about everyone. I think that was Tamara's point. And if the GIC has richer benefits than Mass Health and kind of the rest of the commercial market, I'm not sure that we can afford to do that in this budget year. And so I think a lot about that. But I have heard from Matt and others that part of the issue or part of the strategy, and I think Dana, you just reiterated this, is about, or Darren maybe, it is about using the considerable market power that GIC has to reduce cost in the marketplace. And to me, I've always believed that the GIC is supposed to act as a change agent to improve value in the healthcare space. And I think we really have to focus on that, you know, in the immediate term, certainly in the longer term. So anyway, those were just comments I wanted to share.
Thank you, Eileen. Margaret, you have your hand up, so I'm going to let you take the floor.
Thank you. Just briefly, I wanted to do a level set after a couple of comments I heard from Darren. First being our plans being 1/3 more expensive than the private market. You know, we have a very high actuarial value. So I don't think we can say they cost more, that's a utilization problem. For GIC, as it is nationally, the problem is prices. And regarding GLP-1s, I just want to add also, yes, there are voices around dropping out of the market, sending a signal and backing off demand. I think also we will see, I'm expecting to see other products introduced into the market this year. And I think that will really have a big push in terms of lowering costs in the coming fiscal year.
Yeah, definitely. Our market power as a state is definitely important for us to leverage. Hey, Melissa, you have your hand up. It's nice to see you. And go ahead.
Nice to see you as well. Thank you. Candidly, I'm struggling with the GLP-1 decision, and I understand the value argument of not many people are using this, and so this is an easy thing to cut in order to see savings. But I kind of feel like that's the point of insurance, right? Is that we all pay in, and then when we need it, that benefit is available to us. For me, it's like, what's next? Is it EpiPens? Is it epidurals? What are we going to decide is not worthy of being insured? And that's hard. That's hard for me. You know, I have a budget that I have to keep in the community that I share, that I work in. And once a benefit is eliminated, getting a benefit back into the budget is next to impossible, right? Because other things fill that gap. And so we can say, well, next year we'll look at it again. But once this budget is down, we're not going to be able to just introduce new benefits. And then my final kind of point is, why not follow Connecticut? Why not reduce access? Why not have it be a comorbidity only or a BMI over 40 and eliminate people who are using GLP-1s for vanity purposes rather than for weight loss and health purposes? Thank you.
Thanks, Melissa. Bobby, go ahead. You have the floor.
Yes, thank you. Melissa, I want to thank you for your comments. I agree 100% with them. I have never, in all the years I've been on, GIC or anything, there is nothing that tells me that benefit that we will be able to bring it back, regardless of what outcome the healthcare affordability working group, provides. That benefit is not going to come back. And it is not 18,000 of our members who are on the GLP-1s right now for weight loss. It is 22,000 people who are on it. That's 22,000. And I agree that let Vita Health do their job, right? And certainly not approve for approved GLP-1s for vanity purposes, right? When someone wants to lose 10 or 20 pounds. But there are comorbidities, there are people who have chronic diseases, people who cannot afford to not be on GLP-1s because they will get really sick. And then all those costs will go up. They will increase. There's not one story, not one email that we have received where you can't, you have to sympathize with people. There has to be compassion. The mission of the GIC is to provide high quality health insurance, right? Affordable, high quality health insurance, right, to our members. And I understand the, let's say our fiduciary responsibility. I understand the budget. I understand the politics behind this. But we have a responsibility to our members. And once we vote to eliminate GLP-1s, they are not going to come back.
Yeah, thank you, Bobby. Anna, I see your hand is up, but also I know Dean's has been up. So Dean, why don't you take the floor, and then Anna, if you can go, that would be great.
Sorry, I have a few things that I wrote down that I want to share with the commission based on data requests that I made from the GIC. Can't really do it without reading what I wrote. I asked the GIC for data that included enrollment numbers, aggregate claims, and a full breakdown of every GLP-1 prescription filled in the past year. Who's on them, what other drugs they're taking, how consistently they fill. And I think that the data tells a more nuanced story of roughly 34,000 members on GLP-1. Over 15,700 are also on heart disease drugs. About 17,000 are on hypertension drugs. Obesity isn't separate from those conditions, it causes them. Fat tissue drives inflammation, insulin resistance, cardiovascular damage. So when a doctor prescribes a GLP-1 for weight loss in these patients, they're treating the root cause of heart disease and hypertension, which we're paying to manage. If we vote to eliminate GLP-1s, we're cutting off treatment while we keep paying for everything else. The cardiac drugs, the blood pressure medications, the ER visits, hospitalizations. And I don't think this is a problem of use. I looked at the data. It shows the opposite of about 34,000 members filling GLP-1s. Only about 14% fill every month for a full year. The average member fills for just 7 months. Over 4,000 members filled only once or twice and stopped. So that's not a problem of overuse. That's a problem of pricing. And that's people struggling to stay on the medication. Want to point out that the members who are filling these drugs aren't healthy people chasing weight loss as lifestyle. They're, again, about nearly 16,000 patients on heart disease drugs and hypertension drugs. So these are clinically appropriate uses. The problem is that the effort's not sustained enough to deliver the full benefits. We know that the drugs only provide cardiovascular protection with consistent use. So eliminating coverage pushes more people into infrequent use where they pay some of the drug costs but get none of the long-term benefits. I'm open to working on strategies that use the GIC's market power to drive down pricing. In the future, we should be doing that, but that's work for the future. Right now, today, we have 24,000 roughly members on a treatment that's managing the root cause of chronic disease, we can negotiate better prices without taking their coverage away while we do it. So I think we should vote no.
Yeah, thank you, Dean. The only thing I'd like to make sure that we understand is the vote is to eliminate coverage solely for obesity. So, Dean, to your point about comorbidity, if a member has both heart disease, diabetes, or any other conditions that are considered comorbid, our members will continue to get that coverage. Anna, go ahead, if you could take the floor.
Thank you. I also really appreciate the information that's been provided to all of us to help think this through. I just wanted to make a couple comments. One, I agree a lot with the direction Melissa was going with her comments about trying to focus GLP-1 coverage on the patients who need it the most, like Connecticut did. Unfortunately, though, I don't think that's feasible from my understanding of how the contracts are negotiated, like with the PBMs. And our GIC staff can interrupt me, tell me the extent to which I'm wrong. But I think the way that the contracts are set up, at least right now, is that if we do something like that, it's actually we lose a lot of the rebate dollars that we would otherwise get, and so it becomes like not feasible, and it would have to be something. Margaret's nodding. It would have to be something that we renegotiate in future contracts, which I think we should think about doing. And in fact, I think in order to do something like that, we might have to cut the coverage for everyone to then come back and negotiate the structure of the coverage that we think is highest value. I also want to say that I absolutely think we should revisit a decision like this if the prices come down, if we can renegotiate the contracts to be high value coverage. I think it's very hard. It is very hard to change cost sharing, once you've raised it, but it is less hard to cover things that you can demonstrate are high value again. And then the other thing I was just going to say, I don't think we totally understand how people are using these drugs yet. So it's hard to sort of speculate on how much of it is high value or not. And then the last thing I was just going to say is I just want to remind everyone that these are really hard decisions. And I mean, one of the things I struggle with is remembering that if we, our spending decisions have implications for the rest of the state and the rest of the state budget. And so we can, when you raise costs here, that means we're implicitly cutting something else, money going to the cities and towns or to education. And, it's not totally zero sum, but it is a budget that has to be balanced, right? And so I just want everyone to think about if you want to keep the benefits here, that means cut somewhere else. And what are the implications of that? And we should be really thinking about those trade-offs.
Thank you, Anna. Margaret, do you want to make
Yes.
some additional comments beyond your head nodding?
Yeah, please. Just piggybacking off of Anna. I heard Dean talk about negotiations, and I just want to let the commission know or remind you that back in the fall we did an extensive mapping of different ways we could raise BMI thresholds, different ways that we thought we could target getting the GLP-1s to the members who needed them the most. And it's just like Anna said, we actually wound up losing more money than we saved by raising BMI threshold because we lost so much in rebates. So that is one thing we looked at. We also looked at different financial models and have been in conversations with CVS. So I just want to make sure the commission knows that we have been working on this shoulder to the wheel the entire fiscal year, and it's a really tough nut to crack. And I am really looking forward to, as I said earlier, a third company introducing an option, and I think then we might see more competition.
Yes, no, thank you very much, Margaret. And I believe that with our buying power and our message that we can revisit adding this benefit. So with all due respect, Melissa, let's be the commission that reevaluates this for our members. Rebecca, I see you have your hand up. Go ahead.
Yes, I just want to say that I think we need to put our trust in the good of the people that are working on this extremely hard issue. There are a lot of people that have really given their careers to public service and are empathetic, smart people that are going to be working on affordability. And I feel very strongly that this issue of the GLP-1s will come up again and again. And it really is an issue of cost. And I am putting my faith in using our Commonwealth's market power. And I think it's the right thing to do temporarily, although I have the same concerns as everybody else, including all the people that are making these kinds of suggestions here, that we want to protect the Commonwealth and the residents. And that is all of our goal here. And we're just trying to work out the best way to do that in the short term.
Yeah, thank you, Rebecca. Tamara, I see you have your hand up. You might be on mute, Tamara.
So as humans, human nature, if we have skin in the game, we basically make the right decisions because we have skin in the game. And what I mean by that is if you are asked to pay a copay or a deductible for something, you usually will think twice before using it for something that if it came to you without any cost. And I mean, that's just human nature. So I don't know if this is possible, and maybe Margaret could help on this, is that for those individuals that want the GLP-1 drugs, and I'm not talking about the ones that have diabetes, although the issue that was brought up earlier, I could go to my physician because of my relationship with my physician and ask that physician to give me a GLP-1 drug and really exaggerate something that I may or may not have. I mean, and that's human nature. You sort of manipulate the system, and people know how to do that, and because that no matter what your ethics are, I think it's important that if we can somehow have some kind of a copay, let's say I'm throwing out like $100. It's got to be meaningful. A copay that if you want the GLP-1 drug, yeah, you could have it if you copay $100 a month, whatever that number is. And I don't know what that impact is on the budget. I don't know all those ramifications, but I think it's important that those who want the drug, especially those who are abusing or are likely to abuse the usage of the drug. And what comes to mind is the pain opioid crisis. For those of us that are old enough, we remember when pain pills were fine. It were not a problem to obtain pain pills until they were abused, and that any doctor, you would go to any clinic and they would give you a pain pill, and the doctor would write a script. And that's an exaggeration, but I am concerned that the GLP-1s could get to that point because weight loss is popular by many people to have the right weight, although it's not supposed to be used for just simple weight loss of 10 pounds or so. So what I'm saying is that somehow if we can think about a way, and again, I don't know how feasible this is, to have some kind of copay or deductible that will provide us some relief in our budget, but at the same time also be an incentive for those who are using the drug to think about it before using it for something that is much more cosmetic or.
Yeah, thank you. I do want to remind folks that we do have a motion on the table. I don't know, Dean or Bobby, I see your hands are up. if you're adding new information, or if it makes sense to take a vote and continue to move on, or potentially we say we have 5 more minutes of discussion and then we take a vote on the motion. So I just, from a procedural perspective, I wanted to make sure we're focused on discussion and the current motion.
Oh, I would like to say something. First of all, that I disagree that people, right, that these 22,000 people, or a great majority of them, are manipulating the system. The purpose, Vita Health requires medical records from our members, medical records, documentation that they have other comorbidities, right? It's not, people, Vita Health is not going to approve and does not approve GLP-1s for cosmetic purposes. So I
Right.
disagree
Bobby,
with that.
If I could just interject.
Yes.
So that is correct. So we are only requesting removal for solely obesity. So all the people who have heart disease and comorbidities will still be able to get GLP-1s, and Vita Health will still.
I don't know that is true. It's
so if I can,
that's the motion on the table. Yes,
yeah,
Matt.
if I can just interject on this, it seems like a question of fact, and I've got the team searching this in the background, but we would cover, so we cover today GLP-1s for any FDA approved condition for GLP-1s. That includes diabetes, that includes today obesity, that includes sleep apnea, that includes MASH, which is a kidney-related disease, and there may be a handful of others. That list is growing, but it is a defined list, right? So people who have obesity, in order for them to gain access to GLP-1s through another condition, it has to be for one of the defined FDA-approved conditions. Just want to make sure that we understand that fact.
So Matt, the vote on the table, though, is to remove GLP-1 solely for obesity.
That is correct.
So the data that Dean had, the data you're providing, Bobby, our members would continue to get access. And the thinking that the governor is putting forth to us is by messaging to the industry that these prices are too high for us to absorb. The thinking is that this is temporary, prices will go down, and our members who want it for obesity may get it in the future, along with other innovative solutions that are coming out every day. And that is the task we can put forth to the staff once we get through this session for benefit design and premiums. Dana, I saw your hand go up, then Melissa. Dean, I don't know if we've addressed your comment, but then you can go as well.
Thank you. I'm hearing some anxiety from folks about transitioning off. And so I'm wondering, GIC team, if you can help us understand, if we vote to eliminate coverage for GLP-1s for weight loss, what happens to members who are currently on those drugs?
Yeah, that's a good question. So we've been giving this a lot of thought in the event that the commission does make that decision. So I think, let me just say up front that I think we all acknowledge that this would be substantially disruptive to those members who are on these drugs today to treat obesity. We have an obligation to support our members if we take the step to eliminate coverage for GLP-1s for obesity. So we have a few things that we can do. We are early in the work of evaluating these steps. Number one, we have Vita Health as a vendor. right? And so part of our evaluation of Vita as a vendor was to determine, first of all, we wanted to make sure that in the event that the commission did make the decision to eliminate coverage, we needed to be able to wind down that program, right? But we also asked whether they could be helpful to us and our members as a resource as an off-ramp from the drug. So for instance, helping them to develop a different treatment plan that does not include GLP-1s for weight loss. There are other drugs on the market. They're decidedly less effective, but there are drugs on the market to treat obesity. And there are, of course, a variety of other programs that we can use to support weight loss for our members. So Vita, we anticipate, if the commission makes this vote, sitting down with Vita and saying, figuring out what they can do, how we would restructure their contract so that we can support our members. There are also programs that we've come to know about that CVS offers that would provide a channel for members to gain access to non-covered drugs at the lowest sort of price that is available in the marketplace. So, CVS and other PBMs are responding to this move by many employers to end coverage, and they're trying to find ways to be helpful. So there are some steps that we can take, and we are giving those a good deal of thought, and we will lean heavily into those over the coming months should the commission make that decision. I hope that's helpful.
Yeah, no, thank you, Matt. Melissa, go ahead and take the floor. Thank you.
Thanks. I just have a question about the data. When we show the 22,000 people and the savings in the $40 million range, are those people all on GLP-1s for obesity purposes only? Or are we only going to be seeing a partial savings of that because we aren't sure why they're on it?
Can you say that again? I'm sorry.
Sure. So my question is, we're showing 22,000 people on GLP-1s, and that eliminating that is going to give what I think it's a $40 million savings. But are we certain that all 22,000 of those people are on GLP-1s for obesity only? Or are we really only going to be seeing a portion of those going off and only smaller savings?
Yeah, it's a great question. So, and we have considered that as part of our, I see Margaret raising her hand. Maybe I'll defer to Margaret. Thank you.
Yeah. The 22K reference there are members taking Wegovy for obesity. So it does not count the members who are taking it for diabetes.
But does it include
I think
other comorbidities?
I think I know what your question is, Melissa. So if we have an individual who is obese and diabetic, or obese and has sleep apnea, or is obese and has a cardiac condition, some subset of our members currently on GLP-1s will migrate to the same drug for a different covered service. And we have accounted for those dynamics as best as we can in our savings projections. So 47 million assumes that some number of those 22,000 will find their way to the drug through a different diagnosis. Did I get that right, Margaret? I see you nodding. Yeah.
Nice. Does that answer your question, Melissa?
It does. Thank you.
So go ahead, Dean.
Yeah. I kind of want to restate what I'd said earlier, which is that, we have, so of those on GLP-1, according to our data, we have about 15,700 who are also on heart disease. We have 17,000 or so on hypertension drugs, and we have about 6,000 members that are treating other metabolic issues. I think it's a bad idea to eliminate GLP-1 coverage for obesity, because obesity is not about vanity. I mean, it is for Serena Williams, right? But for our members, they're treating various manifestations of insulin resistance, and obesity is a root cause. Night before last, I got an email from a member of Springfield who made exactly that point in one of the many kind of moving accounts that I heard. This member has been chronically obese, but more importantly, was dealing with hypertension that wasn't responding to the normal pharmaceutical treatments. Once on GLP-1, weight loss occurred, but more importantly, hypertension came down to normal ranges. So that's kind of what I want to emphasize to the commission. We're looking at cost and benefits purely from a financial perspective, but we have to consider the clinical implications, right? We're treating obesity not for vanity. We're treating obesity as treating a root cause that's tied to other chronic conditions that we're also paying for essentially through our health plans.
And it gives me great confidence to know that those patients who have both hypertension and obesity will continue to get access to this
Not
product.
hypertension, Madam Chair. That is not, it's not an FDA approved but a variety of other conditions, yes.
So it's a very difficult decision, and one that's in front of us from a budget perspective, which we also have a responsibility to balance. So here's where we're at, 1 week before premiums have to be evaluated for open enrollment. So it's not an easy decision. I think we're all struggling with it, and we'll look to the staff, if we do remove GLP-1s for obesity, to have a solution for our members, whether it's grandfathered for a certain amount of time or, external sources that provides the drug at the very lowest cost. None of which makes any of us happy. And we do need to find a way to have some responsibility to the taxpayers who also aren't getting a majority, based on the data that we saw, GLP-1s exclusively for obesity. Jane, go ahead. And then I do think we may need to take a vote on the motion and potentially other motions then that we would need to discuss.
Thank you, Madam Chair. This conversation with the complexity of commentary, to me, underscores my original respectful request that we take a pause, a 1-year pause, just to figure out and to come to a more solid position that's fiscally responsible and better serves our members and our long-term stewardship responsibilities. I believe a no vote at this time will cause permanent harm and possibly, in some cases, death to some of our members. And I see no, and in good conscience, this conversation is so complex and so difficult that I think it's one of those moments where we have to say, let's put the brakes on and use a year to really come up with a better decision than simply an easy decision.
Yeah, I mean, I do think that this is a very difficult decision, and we would it be okay if we tried to take a motion on this? Because I think many of us are saying some of the same things, potentially, unless, Bobby, you have something new to add. I wonder if we can take a vote and then we'll maybe have some clarity around what we provide for guidance to the staff.
I just want to say, the focus is through or has been through the financial lens, and it's not our responsibility to balance the budget. It's our responsibility to provide high quality healthcare that's affordable, and the long-term impacts right, for removing people from GLP-1s is a huge mistake. It's very short-sighted. We have to look at it through a health equity perspective, not right, and the disparate impact on lower income members, on members who are, in the BIPOC community. We really have to look at that. And I cannot either in good conscience vote to eliminate GLPs. I like Jane's proposal of delaying that. Or doing something else, but not eliminating the GLP-1s. It's a huge mistake because the long-term expenses are going to develop pretty quickly.
Yeah, I do think, Bobby, that we appreciate your focus, and I do see our role as being so committed to our members and providing them high quality care, which I feel very strongly we do. And we do need to live within some degree of a budget that is affordable for taxpayers. So I think at this point, I'd like to see if we can vote on the motion. So Dana, if you want to repeat the motion, or Andrew, if you should repeat it just for the record, or if I should repeat it, but let's get the motion out there. It's been seconded by Rebecca, and let's take a vote. And I think it will help with clarity and also additional suggestions that many of these commissioners, our commissioners, us, have made for recommendations.
Would you repeat the motion, please?
Madam Chair, I believe the motion is to remove GLP-1 coverage for weight management as is being displayed on the screen.
Yes, and weight management only. So it's one indication only. And Rebecca seconded it. So
do I need to make the motion again?
Nope, it's been made
Okay.
and seconded.
No.
Yeah. And so you've got that for the record, who made it, who seconded it, and now it's time for us to vote on it. And as hard as this decision is, I vote yes.
Vice Chair Kaplan?
I vote no.
Designee Sullivan?
Yes.
Designee Butler?
Yes.
Commissioner Ambler?
Yes.
Commissioner Choate?
Yes.
Commissioner Curley?
No.
Commissioner Davis?
Aye.
Commissioner Edmonds?
No.
Commissioner Guerrand?
No.
Commissioner McEnany?
Aye.
Commissioner Murphy Rodriguez?
No.
Commissioner Pepin?
No.
Commissioner Robinson?
Oh.
Commissioner Silva?
Yes.
Commissioner Sinenko?
Yes.
Commissioner West?
Yes.
The vote passes with Vice Chair Kaplan, Commissioner Edmonds, Commissioner Guerrand, Commissioner Murphy Rodriguez, Commissioner Pepin, and Commissioner Robinson in opposition.
Well, it's with a heavy heart that I hear this, but thank you.
Commissioner Curley, I'm sorry if I missed saying that.
We have that for the record, so thank you, Andrew. And so I don't feel like we are, yeah, let's just continue to move on. But thank you, everyone, for the discussion. A very difficult decision. I feel like we need to revisit this and keep a focus on it for our members because it's an important issue. And let's be the change agent that many of the commissioners have spoken about that we can be in this state. So Matt, I'll pass it on to you for.
No, I think the floor is still open for additional motions if there are others to be made.
Okay, thank you.
Yep.
I know, Eileen, you mentioned a motion. I thought somebody else did also mention motions that may be made. The floor is open for that right now.
So can I go ahead?
Yes, please.
Okay, great, thanks. So I wanted to make a motion for us to consider a new insurance product for open enrollment next year that caps reimbursement rates as a percentage of Medicare. And I say this because there's been a lot of work done by other state agencies, certainly the Health Policy Commission, CHIA, Division of Insurance, others. And the primary cost driver is the unit price of care. And so I think we have an obligation as the largest purchaser to try to move the market to more value-based and to be more efficient. Many other states have either enacted, legislation that allows for this product or implemented this type of reimbursement structure. But I think Massachusetts should consider this, the GIC in particular, because I think, as I said before, I don't want to be here next year talking about how we cost shift to our members, right? And so we know what the issue is. We know it's the runaway unit cost. And I think we have to have the political will and the courage to actually move forward. I appreciate it will be disruptive, but I do think we need to consider it. And so I make that motion that we do for the next meeting.
I second.
Okay. And so I heard Eileen made a motion, and who made the second? Tamara. So
if I may, Madam Chair, I just want to call on my general counsel. Thank you.
Thank you. Can you specify the motion again?
Yeah. So the motion is for this commission to seriously consider designing a product for our members for open enrollment next year that will cap the reimbursement rates as a percentage of Medicare. I don't have that percentage yet. I think that's part of the discussion and the work of the staff.
So
I want us to come prepared and have an agenda item for the next meeting where we talk about this and consider a path forward for having a product that caps reimbursement.
Ejaculation. So what I would, Martin, if you can put yourself on mute. Sorry about that. Andrew, correct me if I'm wrong. That would more the agenda item we're discussing now is FY27 plan design. What the motion that is on the floor is about preparing for FY28 plan and products. What I would suggest is that we hold that motion till other business and we can add it to the agenda for the next meeting. I think, Andrew, correct me if that is the proper parliamentary procedure here. I'm a little rusty.
Yeah, a motion can be made as new business that is not something that is being covered on the agenda. However, it's really a direction for us to consider coming for a proposal, which can be done, doesn't need a vote per se, it's a request. And if the commission would like a more fulsome discussion of that, I think it would be more appropriate to do it at a future meeting. We've already had a meeting where we've talked about our work on rate
procedurally, Andrew, I think that's the answer, right? It's so yes. You can raise this under new business, Eileen, but I don't think it belongs here.
I'll table it to the new business. That's fine.
Well, I just am curious because there was, okay, well, anyways, we will put this and new business. So I see that Darren has his hand up, Tamara has her hand up, and Dana. Dana, I'm going to let you go, and then we'll take Tamara and Darren.
Sorry, I think I left my hand up. Apologies.
Okay, that's okay. Darren, same with you?
No, I actually had a quick question, somewhat of a procedural question. So I know we took the vote on GLP-1s, but do we need a motion to forego voting on the other proposed plan changes, or is that?
We don't need a motion, but if there are other motions that anyone would like to make on any of the other plan designs, the floor is open for that. So someone could make a motion that we disapprove them, someone could make a motion that we approve them, or we could simply move on if there is no motions and those prior items, if there's no motions on them, they don't move forward for consideration. Does that make sense?
Mm-hmm.
Yeah, that's fine.
Do you want to make any other motions there, Darren?
No, I just wanted to make sure that that was the case, that, and I'm fine with that if it just, basically kind of dies on the vine by not addressing it. That's fine either way.
All right, thank you.
Otherwise, I would make a motion to just forego voting on those things or vote them down. Yeah.
No, I agree. But it has been taken off the table, so not necessary. Tamara, you have your hand up. Go ahead.
Yeah, so I had a question about the plan design and cost sharing discussion. Am I to understand that we're not going to have a discussion about that at all today, or is it deferred to March 6th? March 5th, I'm sorry.
No. Matt, do you want to cover that?
Yeah, so the motion was made and withdrawn. I believe the instruction we gave was to Commissioner McEnany, if she wants to raise under new business an item that we can add to the agenda for a future meeting, she may do so at that time.
No, I'm not talking about that motion. I'm talking about the plan design motion that we, the cost sharing.
Yeah, if any commissioner would like to return back to the list of proposals that we've discussed and would like to make a motion on any of those, that is their prerogative to do so. So if you'd like to do one, now would be the time to do that.
Yeah, but my concern is we don't have very much time. I think we need to consider that because that was definitely part of this whole discussion. GLP-1s were just one part of this. And I think we need to, fully vet it out and consider and discuss it. So what I'd like to do is have that discussion at our next meeting.
Yeah. So Tamara, I think the challenge, I don't disagree one bit with you. The challenge is that our members have spoken. We've looked at their data. We've looked at the impact, and clearly they are not in favor of cost shifting. And we do need to be respectful of their request. In addition, the governor has reevaluated what our constituents have been pushing for, which is no cost shifting. And so in lieu of that, there is the reduction of the benefit of, we just approved GLP-1s for obesity, removing that. And that will help us with the budget. At this point, it's not clear we would be able to discuss at the March meeting cost shifting because it's time for premiums to be premium numbers for open enrollment. But I don't disagree. We did not have a robust discussion as a commission post all that discussion. So we opened the meeting with, let's take cost shifting off the table and let's focus on what we can do in the short term. But broadly, long term, we need a better approach, innovation, to give our members both the coverage they want and the budget, living within the budget that we can as a state. I don't know if that helps, but that's how I've viewed the last several weeks of this discussion.
No, I understand, but I think it's our fiduciary responsibility to fully to fully discuss that, since we have not really fully discussed it, irrespective of all the letters we received. I think it is our fiduciary responsibility to consider management's proposal and fully discuss it as we did today in the GLP-1s, because otherwise we're just basically saying that because of all the letters, we're going to do a certain action.
Yeah, if someone on
Matt,
staff can go back.
Matt, I see Dana has her hand up.
Okay. Gotcha.
Thank you, Madam Chair. So Andrew can correct my procedural stuff here, but I really just want to thank everyone for the debate over the last few months on these plan design changes. I do feel like we have had a robust discussion, and the staff has brought lots of different examples and additional data to us for consideration. With that being said, I would like to move to end the debate and move on to the next agenda item. And then Andrew, you can correct me if I did that right or wrong.
That's good enough for us.
Okay, excellent. Thank you.
I second the motion.
Second.
Okay, so we have a motion on the table. Do we need to vote on that then?
Yes.
Okay, so we have a motion, we have a second. Andrew, I'm going to ask you to do roll call. So I'm in favor. I say aye.
Vice Chair Kaplan.
Andrew, could you restate the?
Sure. The motion is to end debate on plan design changes and to move to the next item on the agenda.
I vote yes.
I think it's plan design changes based on the residual ones.
Everything but GLP-1s.
Thank you.
Yes, I vote yes. Then. Thank you.
Designee Sullivan.
Yes.
Designee Butler.
Yes.
Commissioner Ambler.
Yes.
Commissioner Schultz.
Yes.
Commissioner Curley.
Yes.
Commissioner Davis.
Did you say Davis?
Yes, I did.
Oh, no.
Commissioner Edmonds.
Did you say Edmonds?
I did.
Okay. Yes.
Commissioner Guerin.
Yes. Yes.
Commissioner McEnany.
Yes.
Commissioner Murphy Rodriguez.
Yes.
Commissioner Pepin.
Yes.
Commissioner Robinson.
Yes.
Commissioner Silva.
Yes.
Commissioner Sinenko.
Yes.
And Commissioner West.
Yes.
The vote passes.
Thank you.
So we should move on to the next item on the agenda.
Okay, thank you, Andrew.
So I believe the final item on our agenda, with the remaining 10 minutes, apologies to our CFO for always crunching her time towards the end here, but we want to move on to the CFO report with Jennifer Hewitt. Jennifer?
Great, thank you very much. This should be a very short report. It really is just an update on some of the spending trend in recent months that was not yet available at the February 12th meeting. So if you could go to the next slide, please. This table is the traditional monthly spending report for the state budget accounts, and it represents the employer's share of spending. What's changed on this slide from the last time we shared it at the December meeting is that spending for December and January have been added, and some specific elements of spending in July have been modified to shift spending from the employer side to the enrollee account. Previously, all July spending in the asterisk cells was paid from the employer side rather than splitting it as is normally done to allow, and this was done to allow time for the enrollee account to be recapitalized. Staff have completed a reconciliation of the July spending against the FY25 enrollee deficit of 54 million and determined that a shift of 28 million is warranted. That is reflected on this slide as well as the subsequent slides. So we could continue on. Thank you. This is the same report, but for the enrollee side of the ledger. Note that July spending in the asterisk cells was previously 0 and now reflects the 28 million in spending that we spoke of on the prior slide. Continuing on. This shows the projected spending of currently available funding across the months we've completed. Actual spending is layered behind the budget levels to provide further context. As we discussed on February 12th, $91 million in FY25 spending carried forward into FY26 and is contributing to our FY26 shortfall. That spending occurred in July and is reflected in the yellow bar. The chart also shows that actual spending for all the months is above the available funding levels that completed to date. Continuing on to the next slide, that extends the budget projections through June and shows the month-to-month fluctuations to reflect seasonality in health spending, as well as the ebbs and flows of pharmacy rebates and CMS credits for our Medicare population. As you can see, February is the largest remaining month, so I will be very interested to see where spending lands, which should give us a clear indication for the rest of the year. And then finally, on the last slide, this shows the cumulative effects of the monthly budgets and is similar to what we've shown in the past. And so then one final slide. This is the similar chart to what we shared with you on February 12th to share the background on the 300 million supplemental budget request. But we restructured it slightly to group it into categories. As we've noted earlier, 91 million is due to FY25 shortfalls that carried forward into FY 2026. Approximately 132 to 157 million is due to funding challenges in FY26, with the remaining 77 to 102 million due to the FY26 claims experience. All three of those categories add up to the 300 million requested, which I'll remind you is needed by April 15th so that vendor payments aren't impacted. We continue to monitor spending closely and are working with our partners at ANF to refine projections. And I'm happy to take any questions.
I don't see any questions, Jennifer.
Very good.
All right, thank you. So I think we can move on to other business. Unless there is another agenda item, Matt, for us to discuss.
The last agenda item, and if Commissioner McEnany is here, that this would be the moment to request that for a future or the next meeting, we review the proposal that she suggested.
So I'm happy to put forward the motion once again at the appropriate time, but I put forward a motion that the GIC offer as part of its 2028 benefit package a plan design that caps reimbursement rates at a percentage of Medicare to be determined. And that we make this an agenda item for the April meeting.
Yeah, my general counsel advises me it's not necessary to have a motion. We can add it to the agenda for the next meeting. But I guess, Andrew, my question to you is, is it inappropriate to have a motion under new business, or is it simply not required?
No, Commissioner McEnany can make it as a motion if that's what the commissioner desires.
That's up to you.
Or it could be a request.
Yeah.
So second.
All right, I guess we'll make it a motion then.
Yes, so we have a motion on the table. It's been seconded.
Second.
Can I just ask a clarifying question? Oh, Darren, go ahead.
Are we Are we voting to make a motion to actually implement or investigate the implementation?
Um,
I mean, I like the idea, Eileen.
Because
But
I don't think
there's
we
gonna be
can.
quite a bit of, yeah.
We can't make a decision about FY28 plan design
Right,
under new
yeah.
business. Yeah. I mean,
Okay.
we can, the request would be to put on the agenda for a future meeting investigation of, and then the rest of your motion, I believe. Andrew, correct me.
So, it's fine. So I
Good.
revised the motion that we put this as an agenda item for consideration. And I'm going to suggest the April meeting because I think it will take time to discuss and get information, and I don't want us to run out of time. So my motion is that for the April meeting, we put as an agenda item, offering a benefit package that caps reimbursement rates as a percentage of Medicare.
If I may, just for the sake of practicality, can we say the soonest meeting possible? Because I'm aware of staff.
Sure.
I want to make sure we have all the right team. We'll do our best to get it in April. If we can, it'll be as soon as we can get it.
Great, thanks.
Thank you.
Yeah. So we have a motion. It's been seconded. There's a sense of urgency. I think that is what, I don't want to put words in your mouth, Commissioner McEnany. However, the soonest possible, it would be nice to see it in April because it will take time. Can I now ask for a vote to?
Madam
this?
Chair, I see Dean has his hand, sorry.
I
Oh,
want
go
to
ahead.
offer a friendly amendment. Could we consider that alongside the analyses that the GIC staff were working on, different policies being advanced by other states? Because I mean, I think that's a great idea, but that's one of many that I think the commission needs to consider.
Yeah, I'm not sure we can amend the motion once it's been put on the table, so it may be a motion.
No,
or
you can have a motion to amend. That itself is a motion. It takes precedence over the main motion until it's decided if it's made as a motion.
So we have a new motion on the table.
So can I just say, I'm not adverse to this proposal, but I do have a hard stop at 10:28. So I don't know if
you want to accept it as a friendly
motion,
amendment.
or that is something that is a point of discussion at that meeting. But I agree that the exploration of what other states are doing is really important.
Second the motion.
Okay.
Which motion? We have a motion to amend, and we have a motion, a main motion.
What might I suggest that, Eileen, you withdraw your motion, which you can do, remake the motion that you want heard, and then we can just move forward so we can do this timely for you.
You know what? I will accept the friendly amendment in the interest of time. So let's do that. Okay.
Second.
Okay. So at this point, Andrew, roll call, or can I ask if there's any objection to approving this motion at this time? Can we do that, Andrew? Since we
Yeah, I'm not sure. Can we state the motion that we're being voted on?
The GIC put as an agenda item for April or the soonest meeting possible, consideration of a benefit package that ties reimbursement rates to a percentage of Medicare and investigates what other states have implemented to reduce cost.
All right, and that is the motion before us.
And I second it.
Tamara seconded it. So do we need to roll call, or can we do it?
Yes, we do. We need to roll call.
All right. So Andrew, roll call. I'm an aye.
Vice Chair Kaplan.
Aye.
Designee Sullivan.
Aye.
Designee Butler.
Aye.
Designee Ambler. Commissioner Ambler. Commissioner Choate.
Aye.
Commissioner Curley.
Aye.
Commissioner Davis.
Aye.
Commissioner Edmonds,
Aye.
Commissioner Guerrand,
Aye.
Commissioner McEnany,
Aye.
Commissioner Murphy Rodriguez,
Yes.
Commissioner Peppin,
Aye.
Commissioner Robinson,
Aye.
Commissioner Silva,
Yes.
Commissioner Sinenko,
Aye.
and Commissioner West.
Yes.
Vote passed unanimously.
All right, great. Thank you. Thank you, everyone. This has been a very busy and lively discussion. Is there any other business that we would like to bring up at this point? All right. Well, we've given the staff some clear direction and a sense of urgency. So at this point, we'll see you next week on March 5th. And I'm asking, is there any objection to adjourning this meeting at this time? Okay, hearing no objection. Thank you, Bobby. I think you supported no objection. So at this point, I am adjourning the meeting. Thank you, everyone.
Valerie.
Appreciate this very difficult discussion, and we'll see you next week.
Thank
Bye
you,
now.
commissioners.
Thank you.